vaccination, engagement, and distribution in Africa. And with me to do justice to this conversation today are Dr. Ngozi Onye. She is founder, Palon Memorial Hospital. I also have Dr. Chizoba Wonodi. She is the Nigeria Country Director for Johns Hopkins University's International Vaccine Access Center. Thank you for joining us. And the gentleman with us, we have Edwin Ikoria. Edwin is Africa Executive Director for the One Campaign. And we have Dr. Olaolu Aderiola, who is the Head of Response Division, Nigeria Center for Disease Control, NCDC. So thank you, ladies and gentlemen, for making the time to join us. My first question will go to Dr. Onye. Ngozi, this is coming to you. And it's before we get into the vaccine conversation proper. Let's look at the data on the pandemic itself, the virus, the infection, and all of that. We see that there's a decline. That's what the numbers are saying. My question to you is, do you see the same decline with the number of patients that you are getting at Palon?
Most certainly. Now we have well, let me start by saying good afternoon, everybody, and thank you for having me on this program. But most certainly, yes, we have seen a decline. Right now, we have just one patient to admission. Previously, we had all our beds fully occupied. So clearly, the second wave, which was a much larger wave than the first wave, is coming to an end. The bad news is we're expecting the third to do.
All right, so the numbers are correct.
Yes.
Great. But what role, I'm still staying with you, what role do you think that the vaccination program will play, even in the few patients that you're receiving at this time?
The truth is, COVID is with us for a while. And for us to be able to get our lives back, to put it simply, we will need to achieve herd immunity. Vaccination will be one way in which we will increase the number of people who are immune, and that will lead us to herd immunity. So catching the disease is one way of getting immunity to survive it. And then the second way of getting immunity is by being vaccinated. So we will require all products. So like that, we require people who have been infected and recovered. We will require the vaccines, and will also require us maintaining the usual protocol of wearing a mask and maintaining physical distance. I think being the most important of the protocol.
All right, great. Now, talking about herd immunity, which is a great point. Revaccination. We understand that we will need to vaccinate about 70 to 85% of Africa's population before we reach herd immunity on the continent. Now, Edwin, this is coming to you. With the pledges that we've received from countries in the West and other private sector organizations, the efforts by COVAX, yourselves, and Gavi, it means to reach herd immunity in Africa, we will need to vaccinate about, say, 900 million to 1.1 billion people, which speaks to about 1.8 to 2.2 billion doses. The different pledges that we have now only amount to about 700 million vaccines. What efforts do you see on the African continent to bridge this gap, and how quickly do you suppose we will reach herd immunity in Africa?
Thank you for having me. Honestly, I think this is the most complex question that everybody is grappling with right now. The idea here is that to reach herd immunity, we need to vaccinate between 60 and 70%. But we are facing the practical constraints of availability first, in the sense that the manufacturing capacity globally right now is so limited that even COVAX facility or the COVAX program that is committed to vaccinating at least 20% of the most vulnerable and the health workers and all of that have not been able to get what they need in the first place. So even the commitment that you just referenced from that the African Union is getting from Serum Institute of India, from the other manufacturers in China and the rest, it's not like it's available yet. In fact, what we've just heard from the Afro-Exim Bank is that they have asked Serum Institute of India to prioritize the COVAX commitment first. And so that is why you see on the continent, you're getting COVAX distributing what they have right now. But so to talk about timing, that is a very difficult question because it is only what is available that can be distributed. And that is what is taking us back to our campaign around, committing, redistributing the existing doses or commitments that the richer countries have already made, in terms of they put their money first. So they got commitment from these vaccine candidates, in quote, pharmaceuticals that are, testing different vaccine candidates. Now that their bets have paid, now they're getting in excess of 1.5 billion doses that have been committed to the richer countries. And so before any of the pharmaceutical industries would make vaccines available to others, right? Others, including COVAX, they would have to first make meet their commitments to those who have put the money in the first place. And so this is the biggest challenge we're having right now, where we're calling on the richer countries who have already made this commitment and already have kind of secured excess doses that they need right now. For instance, Johnson & Johnson just got approval for their vaccine. It means that the United States will have 550 million extra doses, outside of what it already has committed to it already. And so the main question right now is that to shorten the time, first of all, there is need to ramp up production across the world so that it's not just the facilities that are in North America and Europe that are producing these vaccines that are making that the doses that they're making available is quite limited. So how do they spread the tech across the world so that other countries that have manufacturing capacity can begin to produce? How do they make it a real public good and contribute their tech and this partnership that can really increase access? That is the first case. The second case is that for those richer countries that are already having excess doses committed to them, how could they start donating their doses, back either through COVAX facility or through bilateral deals with low-income countries to ensure that commitments to them actually gets to these people that actually need them. So these are the main questions. So the timing is not what anybody can predict. So even the commitments that have been made are not really readily available right now. So this is the predicament we're currently experiencing on the continent.
Yeah, thanks for that, Edwin. Now, as a follow-on to that, do you reckon that if Africa was as open to the likes of Sputnik and Sinovac as we are to, Johnson & Johnson and AstraZeneca, could there be a more rapid approach to vaccinating the continent?
Okay, so in terms of openness, I would say this is not like you go off the shelf and just pick something. So there are regulations, there are very strict approval processes that need to happen. And so the question is not about being open to a particular product from a particular region. It's about what is the regulatory stage? At what stage of approvals are those vaccines? And to what extent have they been given kind of global recognition? So if the WHO has not really approved for emergency use, as we have with other vaccines, any African country or any other arrangement that gets those vaccines will be seen to be doing it at their own risk. And so the question here we would rather ask is, what is the Africa's regulatory capacity to really assess the efficacy and the safety of these other vaccines that have not been, approved by the WHO mechanism already? And to what extent can we be assured? And to what extent were these vaccines tested on the African continent? For instance, the reason why Johnson & Johnson is kind of the preferred right now is that the trials actually happened on the continent. So those are the kind of questions that we also need to ask. So it's not about just making an ideological decision about products from the West or products from the East. It's about all of the technical regulatory approvals and processes that needs to happen before a vaccine candidate is taken. But that is not to say we're already seeing Sinovac already being used, their vaccine being used already on the continent. We've already seen Sputnik being used in some countries on the continent. The question is the monitoring and the assurance that of the safety and the efficacy that will actually determine the level of openness to these other vaccines. But most importantly is the approval process that requires that global recognition before people can begin to openly take these vaccines.
Thank you for that. Now, speaking to availability, which is what the main crux of your conversation, your point is what we need to do is to ensure that the commitments are then made available. Okay, looking at Nigeria specifically, Laulu, I'm coming to you. We have 4 million doses that's been made available. Reports came out yesterday that shows us that we've only been able to administer about 120,000 of 4 million. So availability is on the one hand, okay, and those who are working on that are working on that. Now the ones that's been made available, we're not rolling out as quickly as we should. Where do you see the hiccups? What are the issues that you see, and what are your thoughts on that?
Okay, good afternoon, and good morning, wherever you are in the world. So the question, yes, Nigeria has received about 4 million, which you mentioned. The rollout, well, we might say it's not as impressive and as expected, but we also know that even before the vaccines came into the country, there were issues with vaccine hesitancy. We eventually got it into the country, and there's been strong leadership to ensure that Nigerians will get these vaccines. You can see that looking at the plans, the guidelines of WHO has given, and what the country has adopted is to ensure we have frontline healthcare workers vaccinated first, and also another frontline personnel in the country. But what we've also added is to let strategic political leaders to also be vaccinated, and also traditional and religious leaders. So that started with the president receiving his first vaccination, and also the vice president. We have several governors that had that. The vaccines have been distributed to virtually all the states, and vaccination is ongoing with healthcare workers. I'm sure by the time we have more data released, there will be more uptake in this vaccine. But we should also note that globally, AstraZeneca had some issues in the European Union with some halting, and that's now stoked up the issues of hesitancy we had in the country. But that the European Medical Agency has really come up that there's really no linkage with that coming up with the blood clots. So the strategy is to ensure healthcare workers, yes, who have given their lives and have been really committed to the responses in the country, should be protected. And once you know that healthcare workers, doctors, nurses have gotten this, it's easier for them to now convince other people, their patients, persons who they have cared for, to also get these vaccines. And mind you, several healthcare workers have been infected, and most of them are also receiving the vaccine now. So we really need persons who will have that first-hand experience to be able to convince the populace. So I guess we are going there in the right direction. Yes, there's been some hiccups, but I'm sure we'll speed up the pace gradually.
Yeah, thanks, Laulu. So speaking to the hesitancy, and I think we'll still speak more to that when we look at the content in the public, and how people have created all these conspiracy theories around hesitancy, but there's also a science to it. And before I come to Chizoba, I see Ngozi's hand up. She'd like to contribute to your point. So please, Ngozi.
Yes, at the risk of doing what you want us not, I just want to give an example. So for example, on Friday last week, the Lagos State Ethiopia local government came to vaccinate payload staff, frontline workers. There was so much resistance. Less than 10% of the staff accepted the vaccines. So we invited patients and people who were at least older people. But then on Monday and Tuesday, they came in, and many more people, the frontline workers, have accepted the vaccine. So yes, it's a question of the major hiccup, I think, will be the hesitancy because of the conspiracy theories.
Thank you for that, Ngozi, because it further deepens the conversation around hesitancy when you see even frontline health workers who are, who have been prioritized, but hesitant to take, the vaccine. And these are people who are science savvy, right? So Chizoba, besides the question around whether it is the sign of the beast, as you hear from the churches, or some of them, and those who say that, it's a ploy to depopulate the earth, starting with Africa, Black people in general. What's the science of it? Okay, in Europe, AstraZeneca, for example, you hear 85% or 93% or thereabout, efficacy, and then in the United States, you hear it's 79%. Why the differences, and what about the science of vaccines or vaccination? Can you tell us to help us understand better why after I take the vaccine, I still need to wear a mask? I still can't hang out with my, people. I still need to take, basic precautions. So what exactly does this vaccine then do?
Okay. So thanks very much for having me. The question around what does this vaccine do is a good one. And I think it's very important to be clear that these vaccines and the trial results that have been released, when you have a trial, you have what you call endpoints. And the main endpoints for these trials were severe disease. So when you hear these efficacy numbers, it means to what extent the individuals in the trial have responded to the endpoints. And the endpoints that most of them actually used were severe disease, so hospitalization, or they had some certain criteria. So if you see AstraZeneca having 70-something%, or Pfizer having 95%, Moderna 94%, it's not appropriate to compare that number or those numbers head to head, because they were not involved in the same trial. So there are several differences in the trials that preclude you from comparing those efficacy numbers. For example, they may define their endpoints slightly differently, and so that might also account for the difference in the numbers. Another thing is that the population that were used in the trial might be different. They might differ in terms of maybe the proportion of the population that has underlying conditions like diabetes and obesity and all those things we know that are related to the severity of the disease. So that's another reason why you should not compare the numbers head to head. Another thing is also in the timing when the trials happened, right? The Pfizer trial happened about middle of last year, and then the J&J happened much later. And at that time, if you look at the epidemic curve, you would see that they were different. And by the time the J&J study happened, the variants had emerged in South Africa where that was trialed. So there are differences in the timing of the trial, the population in the trial, the endpoints, and even the way the measures were conducted. So it is not appropriate for people to compare these numbers head to head and say this is an inferior vaccine or this is a superior vaccine. Like Edwin said, each and every one of them that have been approved for emergency use listing by the WHO have to undergo the same rigorous appraisal process. And there are standards that they all met. And what we need to know is that we have more than 7 now. Well, WHO has, I think they've gone through 4 or so vaccines. We have 4 vaccines that have been approved by the WHO that are safe, efficacious and all that. So what we need to consider as a country is which one fits best into our routine system, which one does not require huge investment in, say, cold chain capacity, which one can we deliver to the end users. And I'm sure many of you have heard this saying now that's become very popular, that vaccines don't save lives. It is vaccination that saves lives. So as long as you're not able to get the vaccines to the people, then you will not get the benefits of the vaccine. So that's really the point I really want to make. People should stop comparing those numbers head to head because they were not, trialed in the same study.
Thank you so much. Now, getting the vaccines to the people is essential. You're absolutely right. All right. But as we've identified, there's hesitancy not only in Africa, but across the world. And some of the things that contribute to the hesitancy in our own environment, one you speak to specifically in the northern part of Nigeria, for example, the polio vaccination many years ago that led to, certain people losing the use of their limbs and, some form of impairment because of that experience. Two, you have, a highly religious social system where people, continue to spread, and educated people, that taking the vaccine is the sign of the beast, like 666. Okay, some chip will be, imputed into you, and then you can be monitored wherever you go. And then you also have the issue around the extermination of Black people to depopulate the earth. And then you have the unfortunate situation around the bad press that the particular vaccine that we have in Africa today, okay, the main one, AstraZeneca, the bad press around this across Europe about 2 weeks ago. And then you also have the fact that, the efficacy against the South African variant, of the virus was, not as effective, and then South Africa stopped the rollout. So you look at all of that, and then you find people taking advantage of all of these elements and, speaking to why people should not take the vaccines. But we don't see enough counter messages, positive messages in the public domain to encourage people to overlook what it is that they've been made to believe and engage, the process. What, in your opinion, Chizoba, do we need to do more of and less of?
Thank you very much for that. It is true that there is a lot of circulating conspiracy theories, misinformation about COVID pandemic itself and the vaccine. And that's really because this is a new disease. At the time it started, it hit the world so hard, and people were left wondering and asking questions. And in that gulf of lack of information, misinformation moved in and filled that in. So that's where we're reeling back from. And then the vaccines now came, and there is a lot of, there are a lot of vaccines in the horizon. And all of a sudden, a lot of people are exposed to scientific information that had been previously the remit of scientists. Now, my mom is asking me about efficacy, is asking me about safety and, clinical trials, phasing. So in all that deluge of information, there's going to be confusion. There's going to be, misinformation. So you're right that, a lot of this negative information are the ones that are taking root, and that's psychological, right? Even if you think about the news is usually full of negative things. You don't see headlines that, give you positive things like, oh, this community is safe and, children are going to school, men are happily married to their wives and everything. That's not going to be headline. So what we need to do is to, everybody needs to really educate themselves. And I think NPHCD and NCDC are doing a fabulous job with putting out information. There are Q&As that they're on their websites, they're passing out through short videos on WhatsApp and all that, but it sometimes is not enough to grab attention of people. They can just read it and move on. And then when they see that, oh, AstraZeneca has been suspended in Sweden and other European countries, that's what's shared around. So I think what we need to do as scientists and as communication experts, we need to first of all be humble and recognize that there's a lot of unknown in this era, right? And that humility and that honesty with the public, that there's a lot we don't know yet, but here is what we do know. I think that can also help to build trust in the information that we're passing out, and get people to receive the information. The next thing we need to do is to look at who are the people that are influential. Who do people listen to? Religious leaders are quite influential. I was shocked to hear from somebody that, I don't know who it was, I was saying that they were told in church not to take the vaccines. So by now, all churches and all mosques really should be advocating for the vaccine. There shouldn't be any religious leader that should still be opposed to the vaccine. So there needs to be concerted effort with these influential individuals to use their platforms to convey the positive message. The other thing is that we need to also vary the type of messaging that, comes out. We know that Nigerians are very attracted to maybe comedy or entertainment and all. More of the entertainment people should jump on the bandwagon and use their unique skills of connection to connect with the right information. So it's going to be a fight between misinformation and the real information. And the more we get people on board to help with the, conveying the right information, like this webinar you're doing right now, I think the more we stand a chance to win this battle. But we have to recognize that we don't have all the answers. There are a lot of unknowns. We have to recognize that there are some people who have a platform whose voices carry better than even the scientists, and we have to bring them on board. And then we have to just keep, pushing out those messages. Thank you.
Thank you, Chizoba. Edwin, I'm glad your hand is up because I was coming back to you. Okay, because most of your work interfaces with both the private sector, the public sector, and these are the people who, or bodies that make the decisions around what communication to put out there and how, what platforms. I hear in Chizoba's points about what NCDC are doing regarding putting information on their websites, pushing information out via WhatsApp. But we must also recognize that the bulk part of our population are not only uneducated, but are not even economically or financially viable enough to access information from these platforms. What do you see? What are you guys doing that we have not seen yet? Now you're probably still cooking. That's coming, to educate Africa, right? What are your thoughts on, the subject?
Thank you again, Demola. I think I wanted to quickly comment on 2 points, just picking back on what Chizoba just finished with, in terms of the role that influencers can play. At one campaign right now, we're in the process where some of our influencers that we work with, again, if you follow one campaign, you know that we work with a lot of the talents and celebrities, as we call them, because of their network, because of their influence, because of their personal connection with their fan base. And so we try to get them on board to also be speaking this language. We did a song mid last year, we called Stand Together. I don't know if you've seen that. I really wish we could play that. And the aim of that song was really to get people to work in solidarity. And the idea is that none of us are safe until all of us are safe, to bring the community spirit, what we call the spirit of Ubuntu, among ourselves. And then when we know that we are dealing with these things collectively, that it's a lot easier to rely on each other, even to get out of this pandemic. So that is on one hand. First of all, in terms of how do we build solidarity, and then how do we get the right statements, the right knowledge. So we did what we call pass the mic. Pass the mic in that case was getting all of our celebrities, talents and influencers, global artists and talent, and to use their own social media, to release their social media handles to the experts who can then give the right information because of their huge following. We reached over 400 million people using that platform. We got got experts in health and the economy to talk about the impact of the pandemic and how we do that. But I really wanted to underscore one point about educating the influencers. This is so vital. You already hit the nail on the head. Very few Africans, relatively, are online. Very few. There's indeed a huge penetration of the internet and mobile and all of that. That is true. But the people who actually have this, what we call the gateway, who actually hold this information because of their access to the internet, that then go out and share, unfortunately, are exposed to a lot of misinformation. And so it is very easy that the gateway, that people that now reach, the majority of the people who are offline will be going with the negative information, with the information that is not really helpful. So 2 things that I thought was important is we need to be concerted in getting all of these influencers in the entertainment sector, in the sports industry, in the music industry, in the acting, or in the theater. And then with the religious leaders, we need to get them to also understand what should we expect from the vaccine. Because there is a misunderstanding, and I think, Chizoba, if we could come back to that question, I don't want to answer it because I'm not a medical doctor, so I also don't want to go beyond my brief. But what is the expectation that the vaccine will do? Chizoba talked about the end point. End point is hospitalization. I was infected this year. and I was in need of oxygen. I had to be given oxygen to come back, because my oxygen level dropped. And if you don't have oxygen, you will die. And there are a few people, because I had pneumonia before, I had some issues with my lungs, so it was a lot easier to be susceptible to this. The fact that majority of Africans have not had first-hand experience of the hospitalization or the severe disease of COVID, it becomes really difficult to communicate to them that this is a treatment or something like that. So if influencers understand the role that the vaccines can play, right? If they can understand the expectation to say, this is the end point, this is what these vaccines will do, and this is how, if majority of the people get it, this is how it helps us to come back to normalcy. That is so important, and I don't think we're doing enough of that. I agree we should combat mark of the beast and combat depopulation and all of those conspiracy theory. That is true, but we should also give the information that people now know, if I take this vaccine, this is how it helps me in ending this pandemic and how we can return back to normalcy. I'm more concerned with the economic impact. 30 million jobs have been lost on the African continent. And that is why they will tell you hunger will kill more people than the pandemic. But how do you end hunger when you don't end the pandemic? These are the connections that we need to be making so that people can see that unless they get involved and the critical mass of the people get vaccinated, we will be in this condition for a longer time and the hunger will continue. I just wanted to underscore those points before we go ahead.
No, absolutely great points to underscore. You've done justice to it. And if we were to trade severity of infection, I think the COVID virus that hit me last year was the senior brother of the one that hit you. Because shut down my organs, and at some point my heart flatlined as well. For about 2 hours, I was out cold. The defibrillator was brought in, and my heart didn't restart. I was essentially dead. All right. But then again, I'm still here. So when you tell me the vaccine is out, I make a dash, for the center. All right. But Ngozi, what role do you suppose the private healthcare sector can play here? People have said perhaps people will trust the private health centers more than they would public. One, there is also that perception that if you go there, you may need to bribe somebody before you get what you need. And unfortunately, we've seen or heard of certain cases where that is the case, and then it just validates this fear, so they don't bother going. Another one is people think that if it's a public health center, they may not even give you the original thing, and we have seen that, yes, people trust their doctor here more than they would trust some doctor in a private health, public health center that they do not even know. So at what point do you suppose that, you should be working closely with the government in, one, educating the people, instilling confidence in the vaccines, and also engaging the vaccination process?
Thank you for these questions. Very pertinent questions. Let me start by saying that the first set of vaccines were given in Lagos on 2 Fridays ago, I'm not quite sure what the date was, at the mainland hospital, where the governor received him and the commissioner of health. I was there. I went to the mainland hospital, ITH, and that's where I took my own vaccine. I took a photograph of myself taking the vaccine. I had my vaccination card, and I posted it on my social media. Unfortunately, I don't use too many of them, but the few I did. So I think that was my own way of trying to instill confidence. The truth is, a lot of the EPI vaccines, even the vaccines we've given traditionally in paper, we've collected from the local government. Unfortunately, the government facilities have this negative image, which is not correct. We collect our vaccines from the local government. I actually tell my patients for the live vaccines, we batch our live vaccines, patients who receive them, and they come at the end of the month because they should be discarded within a couple of hours of opening them. And I said to my patients, if you're not willing to wait till the month to come to pay, then go to the local government, because there I know they open one vial, finish it in a day because they have the numbers and they discard. The truth is, what have we done as a private hospital? We made our premises available to ensure and local government. So they were vaccinating here. People think Pelon is vaccinating. And I say no. Etiosa is vaccinating in Pelon. And someone said to me, oh, I heard your nurse who vaccinated last week. You don't feel any pain at all. I said, no, it's not my nurse. It's the same lady who vaccinated you now. I vaccinated last week as well. So that is one way in which we can work. So they can use our premises just because for some reason it seems to, well, not for some reason. The honest truth is up to 70% of Nigerians access healthcare in the private sector. That's been the case traditionally. So we're not going to expect that it's going to change overnight. So because we inspire that confidence to the local government is doing it. Yeah, that's one way. The second thing is, of course, I realized also that just like at the beginning of the treatment, remember they were shutting private hospitals down. They're taking in COVID patients in March and April of last year. And then eventually they accredited private hospitals. That I think will happen as well. Eventually, the government will have no choice but to partner with the private sector because of confidence, because of also efficiency. They are usually much more efficient. I mean, there have been issues like, oh, my phone is not working for capturing data, or those kind of things are less likely to happen in the private sector than in the public sector. I'm happy to say that the public sector came to vaccinate us here. They didn't ask for bribes. That's the honest truth. I cannot dispute that they might ask in other places, but they didn't ask for any bribes. So I think eventually it will happen. And I think, for example, on Friday, so just adding to some of the things that have been said, my pastor and his wife, my two pastors, the Elevation Church, and I'm happily mentioning it here because I hope some members are listening. They came in here for their health assessments, just the annual health assessment. And we're vaccinating. This was when our own staff were rejecting the vaccines. And so I said to them, Pastor, why don't you get vaccinated? And they both got vaccinated. And I've made a note that I'm going to ask Pastor to bring his card to church on Sunday and say, look, I have received the vaccine. If that will impact the people. Well, unfortunately, my church is a very young church, so most of the people are very young and they don't quite qualify yet for the prioritization, but at least let them be open to receiving the vaccine. There's also the issue of the needs to and the wants to. So in prioritizing, somebody said because healthcare workers have lost their lives and so on. But the real truth is that you need to protect the healthcare workers, the frontline workers. So it's not just healthcare, it's also the police, it's also the rapid response, because you need them to also look after the rest of the population. But then also people who will travel, eventually, whether we like it or not, we're going to need those vaccination passports to travel because it's a global village. So even if, and that's the reason why the Western world has no choice but to also do what they can to ramp up vaccines in the other rest of the world. Because if not, nobody is safe until they are all safe. That's a fact. And it's a global world. So in 6 hours, I can be in New York. That's the truth. And so the truth is, people who are rushing to get the vaccines now are those who recognize that they're going to need to travel. So those will also, they will actually be willing to even pay if you have to build them. Of course, nobody's paying them. But if a time point comes when they have to purchase the vaccines, people will be willing to pay for the vaccine for that reason. And I think it's just a question of patience. I think it will catch up. Because when I see what happened on Monday, on Friday, and what happened today, now the demand today exceeded the supply today in my hospital. That's the truth. Many people were waiting, begging to be vaccinated, and they said, no, you're not old enough, you're not the priority list. And, so I think I was very encouraged by what
Thank you. Thank you, Ngozi. Thank you, Ngozi. You make really good points. And when you were listing the people that are qualified now, you mentioned police, health workers. You didn't mention petrol station workers like ourselves. But I mean, even on the points
I think Dr. Olaolu is in a better position. Better have the policy to Olaolu address the petrol station.
Yes, but Laolu, you had mentioned earlier that most states have gotten the vaccines. I looked at the data that was released yesterday, and I noticed that that quite a number of states recorded zero. Why do we still have states that? So is it a question of they don't have the vaccines yet, or it's that they have the vaccines, they haven't started rolling out yet? And where they don't have the vaccines, what are the issues? And if I'm in a state where the vaccine is not available, what am I supposed to do? Is it certain that the vaccine is still coming my way? or should I go to the neighboring states, to access it? What's happening here? Lalu, that's to you.
Okay, all right, okay, great. Thank you. So the vaccines has been distributed to all the states, and this data is, the thing is, states have an obligation to send their data to NPHCDA on how far they've gone. So at times, this data may not be the total number that have been vaccinated. There may have been some delays in some of the states. Some states got there much earlier than others. And for some of these states, they needed to train their healthcare workers to ensure that the guidelines are followed, safety protocols are there to ensure that they can really do this in a safe manner. So eventually this will move on. The prioritization is actually necessary so that there will be order, and is also based on the epidemiology of the disease itself. You also need to consider those who are providing services so that they have more confidence to treat people. Yes, they are part of the, aside from that, you're also looking at those who have comorbidities, so that those ones will also come on board. So that prioritization, because we can't give to everybody at every point in time. So there are guidelines to ensure that who should be the first to take, and this is based on the data and also on safety to ensure this is done. So we'll find more states coming up with more data by the time NPHCDA releases the next step to say a marked improvement. And just what Dr. Ngozi just mentioned, you can see that the demand is beginning to increase, and so we expect more states to have this. If some really want, no, there's no hindrance to you getting. So you can move to another state, another nearby local government to have this done. But for now, it's healthcare workers that are being prioritized at the moment. Also, frontline workers like the police, the military officers, those working at the airport, rapid response teams. Those are the persons being prioritized at the moment. So it's just for order, for prioritization, to ensure that there is safety and confidence in the system. And this will also deal with the hesitancy that we have. Healthcare workers take it. Just like Dr. Ngozi said, even speaking with our pastor, that brings a lot of confidence, such that, okay, if you collected it, then I too can also collect it. And also to give the right information to people. Yes, there will be some side effects, but those side effects is just that your body is reacting to the vaccine that was injected, which means that you are really actually preparing your body in case you now get in contact with the virus itself. And also to let people know that once you get the vaccine, it doesn't mean you cannot catch COVID. The non-pharmaceutical interventions should still be on, because it will take 2 weeks before the body now kicks in to produce antibodies. So people should still continue wearing their face mask, ensure there is physical distancing, ensuring that there is hand hygiene. This should continue. It will be with us for a time. We've been on this, and we just need to be more patient, knowing that whatever we are doing, we are protecting ourselves and we are protecting others. One key thing is that we still need to ensure that non-pharmaceutical interventions are done, because the virus itself is mutating. So the earlier, the more stringent we are with this, we give the virus no chance to be able to transform itself, because every organism tries to ensure that they propagate themselves. So viruses are also not left out in this. As we ensure that we want to keep ourselves safe, the viruses also want to have more hosts for them to propagate. So I guess that's the message. Thank you.
Absolutely, thanks. So still staying with you, Lalu, the rollout has started, and I'm aware that doesn't sit directly with you at the NCDC. But what are the teething problems that you see now with the rollout? Yes, we've started, but we must learn through it. Okay, to ramp it up, to accelerate it, we must learn through it. So what do you see? What are the key learning areas that you see that you need to let the public know?
Okay, so for this, it's just for the public to know that there is confidence in this. NPHCDA has been rolling out vaccines for years, and just of recent, we were able to eradicate polio in the country. So the infrastructure is there. The manpower is also there. We have the states coordinating this because MPCD is working with all the public health emergency operations centers in the state, and it's one response. Vaccination is just one part of this response. So vaccination is not the silver bullet. Well, it's very, very important, but other things also need to be done. Active case search needs to continue. We need to continue with testing, which is still very, very important, so that we can also track what is going on with the vaccination process. Is the vaccine really working? So these are things we'll continue to work with. And MPHCDA, you know, the main issues about the hesitancy that we have. So they're really working hard to ensure that they get the buy-in of the public, and they are using the traditional rulers just as they used during the polio eradication, which they engage the traditional rulers, religious leaders, and this is what is going on currently at MPHCDA. We're also supporting them in ensuring that messages are going out in this way. But one key thing which you mentioned earlier is not just the social media. We really need to get down to the people in the grassroots, because this is a build-up. It's healthcare workers. So I have healthcare workers at states, at the secondary and tertiary healthcare center, also primary healthcare center. So all health workers within this working in these institutions need to also get the vaccine, and with them they'll be able to propagate this to other persons. So I guess it's we know that there are some issues there, but in terms of logistics, that has been dealt with. It's now for people to come in, and as you know, there'll be some areas in which the demand will be much higher than others. And even from data that MPHCDA released yesterday, you see that Jigawa has really done quite a lot about the target population. They've close to 20,000. So this is really good news. If you look at the north, that people say there might be hesitancy in the north, this is showing that yes, if more is healthcare workers and frontline workers are taking this, it's easier for them to influence others to really get this vaccine done. So by the time we are done with this, other batches of the AstraZeneca will still be coming into the country. So it's just this initial part, but MPHCD is really working hard, and we are also working with them to ensure that the vaccination coverage really moves quickly. And I think that is it for the moment.
Yeah, thanks. I mean, I noticed that take Lagos out of the Southwest, Jigawa has vaccinated more than the entire Southwest, right? And I believe that, you know, because of some of the work that MCDH has done, you know, through the influencers in that environment. Now, to tell our audience, they can ask questions. I mean, if you let us, we'll just continue. We've got about 11 minutes to go officially. So let me see. There are questions in here. Okay. So I am just going to pick. One second, please. Please send in your questions. Okay, my question is, this is from Lawrence Chinedu. What are the current network and initiative put in place to sensitize and distribute the vaccine to rural areas? I would suppose that Laulu, this is coming to you.
Yeah. Okay. So as I said, MPHCDA has a huge network to ensure that vaccines really move on. Good enough, AstraZeneca is what MPHCDA has been handling. So the structures are there from the MPHCDA at the national, there are zonal offices of MPHCDA. They work with the states. They have the state primary healthcare boards who are really tasked with this. And, you know, it's linked to also the primary healthcare. So every ward has a primary healthcare, and this is something that is being done. As we said, they are working with the gatekeepers, traditional rulers, religious leaders, the gatekeepers within the states, and other mechanisms are also coming up. As we've just discussed about influencers, entertainers, and the Nollywood, the Kannywood. So those are areas that will also be coming on board to ensure that is done. Then there are other partners that MKCDA works with, UNICEF. There's various avenues in which they pass information. There are dramas that are done at the local level, drama for change and all that. So these are other things that should be done. So those plans are in progress with MKCDA, but as I said, for the meantime, it's about the frontline healthcare workers now. Then it will now roll over to the other segments. We're just in the first pulse. By the time other vaccines, the other batches come in, then that will also really help.
Thank you, Lalu. There's another question here, and I know that we have spoken to it, especially when Edwin was addressing a different point, speaking to how the study phase, the test phase for these vaccines. But to Chizoba, this question says, is there any African studies that we do by ourselves to test these vaccines, or are we just relying on once the West approves it, then it's good to go?
Yeah, I think the first thing to say is that Nigerians, Africans have been critical to the studies that have been done. I'm sure most people have heard about, I think, Dr. Buago at Yale, who led the clinical trial of the Pfizer vaccine at Yale. But in terms of leading the studies in the African continent, in South Africa, there were studies done in South Africa. Both the J&J study was done in South Africa, as well as the AstraZeneca. They had sites in South Africa. But I think the main thing that we're pushing for really is for the science to come to Africa, for the African researchers to be supported to do more, to take the leadership on vaccine studies, and for vaccine manufacturing and vaccine production to take roots in Africa. But I have to say that, yes, African scientists have contributed significantly to what we have right now, but we still need to invest more to support our scientists to take the leadership and develop homegrown vaccines and homegrown products. Another thing that we've been pushing for really is for technology transfer to Africa, so that we can have some vaccine production hubs in Africa, say South Africa, Nigeria, and all that. So there's really been a strong push for that at the global level, so that if the next pandemic hits, we don't have to all rely on, few manufacturing bases in Europe, America, and thank God for India for coming to the rescue of the world. Thank you.
Thank you. I see that Edwin and Ngozi would like to contribute to that. So Edwin, you first.
Okay, thank you. I just wanted to say that our regulatory agencies like NAFDAC, for instance, are also involved in before any vaccine is deployed in each country. There's a whole process for each national regulatory system to also examine what they are getting and see that it actually conforms with what the expectations, with what their documents say. So it is not like because it has been approved by WHO, it goes straight to distribution. So there's the national regulatory process itself that has to also review what has been submitted or what is available, and then see that it actually, it's safe, or it at least does what it claims to be doing before it gets rolled out at the country level. At the African Union level, there is this network there's this network that exists to do that, and they've streamlined the process to make sure it's efficient, it is clear, that the documentation is also very clear. I just wanted to underscore that point to say that it is not because WHO has approved or it's approved in Europe, so it will consume it in Africa. Each national agency for drugs are also involved.
Great, thank you. Ngozi.
I was just going to add that, for example, I took my own vaccine about 12 days ago. Did I have any side effects? Negligible. But because I was one of the very first to take in Lagos. My children, my son particularly went into a panic and talked about the blood clots. So I decided to go D-dimer. The D-dimer is a test, and it's fairly expensive on that test. The level of your predilection for predisposition for forming blood clots. And the normal level for my lab is below 500. Mine was 1,800. Unfortunately, I tested 3 days after I had taken the vaccine. So I put myself on the blood thinner. But what I immediately did was I said, we're going to take at least 30 people. We'll take their samples random. We did random selection. We will take their samples before they get vaccinated. They will come back 3 days after they're vaccinated, like I did, and we will repeat. We're doing this at our expense. Each test is at almost 20,000, about 18,000 naira per test. And we are doing this at our expense. We're not charging the patients. Just for us to, or the people, just for us to see if my own D-dimer levels went up because I took a vaccine or because I already had elevated D-dimers. We should not forget, these are not things we routinely screen for. But people have always had pulmonary emboli or DVT before because they had elevated D-dimers. We just were not testing. We haven't collected our data. We collected all the people. We haven't looked at the data. But already we have about 4 or 5 people who came in with very high D-dimer levels, even before they were vaccinated. So if any of those people had gone on through an embolus, if the vaccine would have been attributed to the vaccination, which clearly it wasn't. So what have we learned now? For people who are older in particular, I say to them, check your D-dimer afterwards. And maybe you need to go on the blood thinner. Maybe this was just a good opportunity God gave me by being vaccinated to find out that I had a predisposition to getting a blood clot in my lungs. So these are small studies. We intend to publish. 30 people doesn't say a lot, but at least it adds to the body of knowledge. And if one had more money, one will do even more. So yes, we are doing our own little studies in Africa. I know Luth has done something to do with treatment and ivermectin. We are doing something to do with D-dimer. We might scale it up eventually if the government will partner with us. Dr. Lao.
Which takes me, your point, Ngozi, takes me to my next question to Lalu. And you would also, of course, Lalu, get the opportunity to contribute to the ongoing. And that question is, it comes from the audience. What's the delay? Why is the government not involving private healthcare sector in the rollout of the vaccination now? What exactly is the delay? What are we waiting for? What are we afraid of?
Okay, thank you. So I guess I just wanted to really talk about the research and noting that COVID-19 is new, and because of that, there's a Nigeria COVID-19 Research Coalition, which is already in place, which has scientists on board. We had a webinar on the 27th of February, which looked at research questions that the team is already working on. So I'll give the link to Dr. Ngozi to really join this team. And yes, what he's doing is also part of research, and which is very important for us to really understand what is going on. And even for this vaccine, there's there'll be a vaccine efficacy study, which is being spearheaded by a coalition also by National Primary Healthcare Development Agency, NAFDAC, and NCDC, looking at the rollout of the vaccine. And to the question about the private sector, we know, yes, most people go to the private sector to be vaccinated. But as you know, the MPHCD, yes, is largely public, and private facilities also vaccinate. So they usually get their vaccines from the local government. It's about the volume and quantity of the vaccine that has come out. And there are still some things that, when you start something new, your plans are there, but there could still be some hitches. So this is just a learning process. I'm sure this will also be extended to the private facilities. As we know, in other countries, like in Germany, they're also thinking of using private GP doctors to ensure that the uptake is higher, because their patients trust their doctors much more. So these are viable options that the government is going to use. As you know, when COVID hit, it was initially in the public sector, because before that was now extended to the private. I know part of the thing is also to look at health worker safety. You also have to ensure your waste management is done properly. So those are things that are considered to bring in the private sector on board. But this is something that is still work in progress, and that will continue to increase. Dr. Ngo just talked about the team in Lagos using her facility for vaccination. So that is something that we're rolling out. But it will be, this would be on a state-by-state basis. You look at the demand and where you need to really engage, and also look at the resources you need to also put in there. PPEs have to be adhered to so that healthcare workers don't get infected. Yeah. Thank you.
Great. Thanks, Laolu. We're right on the hour. We have spent 1 hour, and it's so interesting how time flies when you're having a great conversation. But let's wrap it up, and I need a closing remark from each one of you, speaking to what you want the key takeaway of our audience to be. And then when they leave this session, they should be confident enough to go get the vaccine. I will start with you, Edwin.
Thank you again. I just want to quickly say that, first of all, there are two key things that I thought that are important. First is that it is time for Africa to move from depending on the West for its own vaccines and medicines and safety. It is time. If there's anything this pandemic has taught us, is that when the chips are down, you are on your own. That is what we have seen. And so right now, all the talk, it's time to move away from talking into actually putting down the infrastructure. And I think it is important for the private sector to also cash in, to say that if we're importing 90 to 94% of our therapeutics, of our medicines, there is a huge market, 1.3 billion people on the continent who will get sick, who will be exposed to all kinds of things, who need to be producing, who need to get access to these drugs. So that is one. So what will the government need to do to ensure that this happens? That is one big takeaway that I would like people to begin to advocate for. The second part is that the vaccines availability is not the end of vaccines is not the end of the pandemic. It is only until it gets into people. And so please, wherever you are, it would be great to always talk about the fact that unless we reach herd immunity, unless a critical mass of people are immunized or are vaccinated, this pandemic will not end. And that will continue to have effect on the economic angle, which will affect you and I. We may not get sick today, but we cannot travel. The global supply chains will not go back to normal. Travel and tourism will not go back to normal, and people will continue to face hard times. So unless we get together, get a critical mass vaccinated, this is going to stay longer. And that's what we really don't want to continue. Thank you.
Thank you, Edwin. Chizoba, over to you. And please, in your response, somebody from the audience would like to know if pregnant women can take this. I know there's some research still ongoing, but please speak to it as well.
Okay, that's a great question. So what we know right now is that pregnant women were not included in the trial, which is it's a gap that, colleagues of mine and I are addressing. However, there are studies that have been done in pregnant laboratory animals, what we call reproductive toxicity studies. And for Pfizer, for Moderna, and for AstraZeneca, there is no data that shows concern, right? Why the vaccine should not be given in pregnant women. The other thing to know is that pregnant women have a higher risk of severe disease. They have a higher risk of spontaneous abortion if they are infected with COVID, right? So the risk of severe disease, the risk of death, the risk of adverse childhood outcome is worse for pregnant women. So that means that there is a case to be made for pregnant women to be protected. And the available data does not give you so much concern that you would overlook the elevated risk of COVID among pregnant women. So the current recommendation is that pregnant women who are at high risk of exposure, for example, healthcare workers or pregnant women who have other comorbidities like diabetes and obesity should discuss with their doctor to evaluate whether the risk of COVID infection, risk of the vaccine or known risk is outweighs the benefits. So most of the countries are actually giving to pregnant women. So the short answer is it's not contraindicated in pregnant women for Pfizer, Moderna, and AstraZeneca. So it's not contraindicated, and it is being given to pregnant women, particularly those at high risk. Now, so what would I want to, yeah. So what's my takeaway
Go
message?
On, please.
Two things. One is that I think people need to have confidence in the vaccine. Why? Because they have gone through the strict regulatory processes, and even in the development, no shortcuts were taken. So the vaccine development protocols were adhered to. That's number one. And in that instance, everybody really needs to be an advocate for this vaccination. Like Edwin says, if we don't get herd immunity, we can't get out of the pandemic. And one way you can be an advocate is to not be a vehicle for misinformation or disinformation. The way to cut down disinformation is to actually have the disinformation end with you. So if you have outrageous claims of things around the vaccine, just check before you forward. Google and check before you forward. Don't forward because you received it on your phone and you just want to pass it on. You have a responsibility, a duty of care to the people around you, to the public, to Nigerians, to not contribute to the misinformation that is fueling the hesitancy. So, and then finally, I would like to say that MPHCDA and partners have put in place a tight program of vaccine delivery based on years of experience fighting polio. Nigerians should have faith in that process. There is a prioritization scheme. So if you don't get the vaccine today, or if you see that they're only 3% vaccinated, that is by design. That is going to come down the pike. And there are some constraints that are beyond MPHCDA. For example, the vaccine doses. There are only 4 million doses available. So let's be patient. And when is our turn? Let's go get vaccinated. Go register. If you're 18 years and above, go and register. And when is your turn, you will receive information of where to get vaccinated and then do so. So thank you very much for the opportunity.
Thank you, Chizoba. I noticed that Ngozi was applaudingly agreeing with you when you were making your submission. Now, Chizoba, to you. In your response, could you also kindly make clear, I know you had said that you put yourself on blood thinners after you took the vaccine, but there's a question from the audience because they couldn't hear you well. They wanted you to confirm if anyone has the propensity for blood clots, are you saying that they can take blood thinners? They shouldn't worry. Go get the vaccine. You can take blood thinners. Over to you, Ngozi.
Yes, that's what I'm saying. I didn't know I had the propensity for blood clots before I took the vaccine. But even if I did know, I would have gone to take the vaccine. I'm actually grateful. I now know. But then more importantly, my own last word is, we must remember that the vaccine is like catching the disease in a small dose. Whatever adverse effects the vaccine can give, the illness gives in multiples. So I said, for example, my D-dimer was 1,800. I have had patients whose D-dimers were greater than 10,000. It means we couldn't even report them. It was beyond that, gone off the chart. So I'd rather take my chances any day with the vaccine than the illness. And those are the two choices we have. Take your chances with the vaccine and the minor. For example, one side effect I also had. The first day, the next morning after my vaccine, I couldn't smell. the anosmia we all talk about. I actually sprayed my strongest perfume on my hand, and I went into a deep panic in my head. But before I left for work, 2 hours later, it was gone. So I'd rather have a 2-hour anosmia because I took the vaccine than have anosmia for 10 days because I got the illness. Or take a small increase in my D-dimer and the vaccine, than the huge increase that will come with the illness. So any day, I think it's a no-brainer, the vaccine or the disease. Any day, the vaccine.
Thank you, Ngozi. Now, Laulu, so, well, Edwin in his response, okay, inadvertently answered a question from the audience, which was about, when do we as Africans begin to look inwards, reduce our dependency on the international community to deal with issues? There will still be another pandemic, all right? It's coming sooner or later. We all just only hope later, okay? How do we as Africans build the capacity? And I ask you this because, this is part of the work that you do. What resources or support do you desire from the private sector, from the general populace? What is required for us to begin this journey and become self-sustaining? Now, before you answer that and then give us your conclusive thoughts, I know that we have set up, and Edwin, has worked on this in recent time, and that's the African Medical Supplies Platform, okay? And, but that's for supply chain management, not necessarily, even though it covers local manufacturing as well on the continent. But how do we expand this capacity? And, to that end, as a matter of fact, I'm compelled to have Edwin speak to that, again, so that we can all understand what that's set up to do. But let's take the input from Laulu, and then we'll close on Edwin, speaking to us about what the African Medical Supplies Platform is set to do, how it manages supply chain for medical consumables or equipment even. And then, of course, how do we use that platform, expand its scope to deepen local manufacturing on the African continent? So, Laulu, to you first.
Okay. Yeah, thank you. So I guess the key thing that has really come up with this pandemic really shows that health is really wealth indeed. And it's everybody's responsibility, not just government, but the private sector. COVID coming in as a team with several organizations supporting government in this, and this was a whole of society approach. We had the media coming on board to ensure that we all end this. We knew that we had learned lessons from the Ebola outbreak of 2014, and Africa in itself has also seen it through the African Union. You have the Africa Centers for Disease Control, you have the West Africa Health Organization, you have the NCDC coming on board to ensure that health security is really given that prime place in our health system. But you know that this will not cut it alone. Universal health coverage is also part of the thing, and this has really shown the weak health system that we have. Yes, I think Africa was lucky. The pandemic didn't really hit us as hard as as was predicted. But we also know that Africa continent really prepared for this. There was a lot of political buy-in to ensure that resources were made available. You can see that Africa, we've had several outbreaks, and you have so many public health institutions coming on board to ensure that we can really work together. We still need more resources for health. As you know, this is still an ongoing issue, but this has really brought to the light that we really need to build our institution as a country and as Africa so that we can have that collaboration, because when we work together, that's when we can have that. I want more private sector involvement so that the responses they give, the funding they give is not just focused on when an outbreak occurs. There's a lot that needs to be done in the preparedness aspect. That is very important, is when we prepare and really look at the diagnosis that we need to have, producing our own vaccines. In fact, Nigeria were producing vaccines before. This is a point in time we need to to really bring that back on. We're producing yellow fever vaccine in the past. So we have that capacity to really get this. So it's just a rallying call for every one of us, the government, the private sector, to really come in and put in resources into this. We can see what Bill Gates is doing with the resources he has. We need everyone in Africa to also put that, and let's research. It's research that really help us to have our own grown response to this. So the African continent, Nigeria, really did a lot in preparing for this. And yes, we have a young population to advantage. Yeah, so that has really helped that most of the cases were mild, but this has brought to the fore that health infrastructure is very weak. Oxygen was an issue, but all this is all building up. So we really need to build back better in Nigeria and in Africa. So part of my closing remarks is that please, we need everyone to get vaccinated. Yes, there may be some side effects, and this is not on. You have a few persons that will have some of these symptoms. The NAFDAC has already launched a medical app so that any form of side effect that anyone has, if it's just pain at the site of the injection or just fever, we need this to be documented. It's part of the surveillance that every country has signed up to. So if there's anything, we want people to go to the NAFDAC website. There's a med app that you can make this report to, or any NAFDAC official within the state, so that we can have this data, so that we can improve on what we do. And our non-pharmaceutical intervention should still continue. The face mask wearing should continue. That should not reduce. Cases are reducing. We want more tests to be done. I want the health practitioner to ensure that more tests are done. We have the case definition is there for healthcare workers to ensure that persons are tested. We need people to ensure that there's still physical distancing. All the protocols we have should still be in place. And President signed the COVID-19 regulation, which has really helped some enforcement. You now see people in public places now wearing masks, though not properly done in some cases. We need people to use their masks, especially when they're in an enclosed environment, and ensure that physical distancing is done. So thank you.
Thank you, Laolu. In 1 minute, Edwin, tell us all about it. All about it in 1 minute.
It's not, I mean, I think for me, that was the most amazing response that the African continent did in terms of in response to the COVID pandemic, the creation of that the supply platform. In fact, it is an example for the rest of the world. If the whole world did this, I'm sure it would have been a lot different from what it is right now. So first of all, it took out middlemen. That's the good one. It took out traders. So it provided a platform for manufacturers to supply directly to countries that need them. It also provided a place for aggregation, right? So that if you have small from Lesotho, small from Namibia, small from here, all of these can be aggregated, and one supplier can bring it and get the price. So that collective bargaining can happen. It was amazing, and I think that was something that we should deploy at a scale. And I think in answer to your question about how then do we begin to increase local capacity, the Conference of Ministers of Finance is going on right now. I think it's almost about ending at the ECA, the UNECA. And this was a major part of that. There are potential. There are some manufacturers that have built capacity over time that also need to be assisted. Pasteur Institute in Senegal, the Aspen, I don't know the name of the full company in South Africa, and there's another one in Morocco and in Egypt that have built capacity over time that are currently producing other kinds of vaccines, right? That we need to make into a hub. I think Dr. Ozumba mentioned that. To think about the hub system where we are all, Africa is thinking in a collective. I think that is our easiest approach to begin to build our internal capacity first. But notwithstanding, Nigeria particularly has a large market. And so if we're able to create the environment, but besides, we had pharmaceutical companies in Nigeria before that were manufacturing, but are closed down. If we begin to examine what was the condition that led to these pharmaceutical companies to close down, how then can we improve those? How do we increase, what do we incentivize for these guys to come back and to partner with global giants, you know, to have a local subsidiaries. Those are the kind of approaches that we need to see. And I think that this is the thinking right now. It's about bringing in the political capital to make sure that it happens. The plans are in place. There's even a roadmap already developed. We just for us to now begin to see them turn to reality. I'd like to close on that note. Thank you.
Thank you. Thank you. Thank you, everyone. Thank you so much. It's a very robust conversation to have, and we could just go on forever. So be rest assured, we will call you again. So Chizoba, thank you. Ngozi, thank you. Laulu and Edwin, thank you so very much. My own closing remark is simple. If you're afraid that the vaccine will kill you, well, they have given it to your health workers. So if they die, you're toast. So let's all go get it. Okay, so on that note, I would like to bring this session to an end. I really appreciate your time and contributions. Thank you. Thank you very much.